Orthopedics just started their SWOT analysis. We are trying to get data, including data from the hospital about our clinical care and environment and that sort of thing. So that is happening on the program side. In the meantime, the same time all that's kind of going over here, they recognize that all of this graduate medical education training, 90% of it is happening in clinical environments. And the accreditation bodies for graduate medical education have never in any serious way looked at our clinical learning environments. And so the point came out, can we really produce good doctors if we're training them in bad hospitals, bad clinical environments? Are we just perpetuating bad habits? And I think it's an excellent question. And then we come up with, well, how do we define a bad hospital? And maybe there aren't bad hospitals, but there are certainly hospitals that have more harm events, where there are bigger problems in the patient care environment. And so, again, at the national level, they brought together a committee of a variety of different kinds of experts: educational experts, clinical experts, hospital administrative experts, nursing leaders, all sorts of patient safety and quality experts. They brought them together and they said, let's think about what the optimal clinical learning environment for a resident trainee looks like. And what are the things that we want to focus on as we go into hospitals and we look at how clinical learning is happening in this environment. And they defined a number of areas that they decided would be focus areas in their pilot project, in which they were going to send a team to do 2 to 4 day surveys in every primary teaching hospital in the nation. So the areas they defined, and hopefully I'll remember all of them. First one is patient safety. So what are your patient safety priorities in your hospital? Quality improvement. What are your primary hospital quality improvement initiatives? Supervision. How do you assure that trainees that are doing procedures and taking care of patients, how much supervision they need? Is it always available when they need it? How do nurses know who should be doing what? That kind of thing. So supervision. Professionalism. Do we have integrity? And are we nice to each other? And how do nurses and docs interact? And all of those sorts of pieces. Duty hours and fatigue management. How do we manage really being excessively tired in the clinical environment? And do we just push through? Do we have ways to help each other? That sort of thing. How are hospitals looking at healthcare disparities? And what are they doing about that? And then I think the last one is handoffs and transitions of care, and how effectively are these being done in your organization. So those were really that 7 focus areas. They kind of put healthcare disparities in the quality piece, so they called it 6, but those were the focus areas. And we were the 13th hospital in the nation visited, so we were early in the process. They came actually 27 months ago, and they're due to come back next month or June, so we'll see how that goes. They came, it was a team of 3 folks from the ACGME. They spent 3 days here. They met with 2 separate groups of residents, 2 separate groups of faculty, 2 separate groups of program directors, and then they spent a total of 6 hours going all over the hospital and randomly talking to people. So they stop and talk to a nurse and say, so how do you know if a resident is okay to do whatever procedure they're doing unsupervised? And what do you do if you're worried about something? And have you ever seen a resident make an error, and what do you do in that case? Have you ever made an error? Can you report that without worrying about it? Where do you report it? How does that happen? And they start, the surveys don't even happen unless the CEO of the hospital is present. And one of the really good things that has come out of this is for lots and lots of years, GME has in a lot of places operated mostly within the School of Medicine. And we've been lucky here in that we've always had a good dialogue just because of our structure between the CEO leadership of the hospital and the GME and the dean of the School of Medicine. But that's not true everywhere. And so this was the first time in a lot of teaching hospitals that the CEO of the hospital and the associate dean for GME DIO sat down in the same room with the chief nursing officer and the chief medical officer and all talked about what are the residents' roles, how do we get them integrated, how does this work. So they have, March 31st was the last visit of the 300 or so initial. They were doing the primary hospitals first and they finished, and so they're about to start the next cycle. What we've discovered, and these were not accreditation visits per se, they were formative visits. So back to Tom Naska's thing about helping you figure out what you need to work on. And it's really provided a wonderful impetus to do action planning internally for program improvement, and we've had a lot of things happen. We have a whole lot more things that we need to happen. And they have recently put out a Pathways to Excellence document that is really presents what is the optimal and clinical learning environment for graduate medical education. There's no environment and no healthcare environment in the U.S. that is doing all of those things. But it really does give you a roadmap to where we want to go, and we're working on it. So the plan is for that cycle to happen every 18 to 24 months. And in the meantime, you'll be on that 10-year cycle that's looking more at your specific, the teaching policies and how the Graduate Medical Education Committee works and that sort of thing. So that's kind of where we are now.
Well, thank you. I really didn't even realize how timely this interview would be, but I have certainly learned a lot. And when we pick up again, we'll talk about milestones.